Well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckbill and I will be serving as your program facilitator and will present your questions to our panel of physicians. This evening, experts in family medicine, OBGYN, and internal medicine will discuss preventative care, screenings, overall wellness, healthy aging, and the importance of putting your own health at the top of your to-do list. Remember, the steps you take today are your first steps to a healthier tomorrow. Well, thank you for submitting your questions in advance. And the questions that you will hear me asking the physicians are submitted from you all right when you registered for this webinar. If you have any additional questions throughout the discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you should see an icon that says Q&A, and you can enter your question right there in the text box. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during this virtual event. And due to hospital university guidelines and privacy, we are unable to comment on specific cases. Likewise, if you're experiencing any symptoms that may require immediate medical attention, please consult a medical professional. Finally, don't worry, we've taken the liberty of muting everyone's line to eliminate any background noise, so feel free to move around and get comfortable. So with that, I want to go ahead and introduce our experts for this evening, starting with Dr. Nyasha George of Primary Care, Dr. Rebecca Jackson of Obstetrics and Gynecology, and Dr. Elizabeth Boyle with Internal Medicine. Well, thank you all for joining us this evening. I know we have a lot to discuss with some great audience questions already submitted. So let's go ahead and get started. I will kick it off with Dr. Boyle. So the first question for the evening, can you talk about what screenings women should get to prioritize their health? And are there different screenings for different age groups?
Sure. Well, hello, everyone. Like Sarah mentioned, I am Elizabeth Boyle, and I'm an internal medicine trained primary care physician here at Jefferson, and I'm here to answer some questions tonight. So to answer Sarah's question, there are a lot of screenings that the average woman is eligible for and should, speak with their primary care physician about. So I'll touch on some of the high points, but I would recommend that if you're in need of any of these, to visit your primary care doctor for an annual physical. So first and foremost, cervical cancer screening is a really important screening to undergo. We usually start this screening around age 21, which I think we'll go into a little bit more detail about later. Breast cancer screening is something that you should discuss in detail with your PCP or your OBGYN as well. This can start as early as age 40 or sometimes earlier if you have a strong family history or any genetic conditions that might predispose you to breast cancer. But depending on which guidelines you're following, sometimes people don't start breast cancer screening until a little bit older, like age 45. And that's why I think it's important to have that individualized risk assessment with your PCP or OBGYN. Colon cancer screening is the next thing that I recommend for all of my patients. The screening guidelines have actually changed for colon cancer in the past 2 to 3 years, and they are now recommending colon cancer screening starting at age 45, where it was previously at age 50. So that's kind of something new that everyone should start to kind of think about. Other cancer screening that might apply to you, but might not, would be lung cancer screening. So certain subsets of the population, specifically smokers who have smoked for a certain duration of time and smoked a certain amount of cigarettes over their lifetime, could be eligible for a low-dose CT scan of their chest to screen for lung cancer. If you think that if you have a smoking history and you think you might be eligible for this, it would be great to bring it up with your primary care doc. So that's kind of the main cancer screenings that we have. And then just a couple other screenings that you can do. Osteoporosis or low bone density is something that women should screen for, specifically after they go through menopause. We usually start around age 65 unless somebody has risk factors for developing osteoporosis at an earlier age. Certain risk factors for that could be a smoking history, heavy alcohol use history, low BMI or low body weight, among other things like steroid use in the past, that being like steroids prescribed by a physician, not anabolic steroids. So also, if you have a lot of exposure to the sun throughout your lifetime, it's probably a good idea to see a dermatologist or your primary care doctor to have your skin checked on an annual basis. If you ask a dermatologist, they won't give you a specific age at which you should start doing this. So if you think you're at risk of sun exposure, or if you have moles that are particularly worrisome to you, it might be a good idea to schedule an appointment with your PCP or dermatologist. And then a couple other things that are important to start screening for are things that are not necessarily cancer related, but your cholesterol, which is related to your heart health. I like to screen all of my young, otherwise healthy adults for this. So, it's never too young to start screening for cholesterol. I start seeing patients at age 18, and I will get a cholesterol screen on all of my patients. And then importantly, screening for diabetes if you're at risk for this, whether it's through a family history or if it's due to elevated BMI. That's something that we can do by blood test. And then there's new screening guidelines for hepatitis C, which is a disease of the liver. And the Center for Disease Control now recommends that you screen all adults for this, where it used to just be certain subsets of the population. So most people have not had this screening test done yet, and it's a simple blood test. And then lastly, I think this is extremely important, and we do this every time you come to a doctor, is blood pressure. It's very important to have your blood pressure checked once a year at your annual visit or at any of your doctor's visits to screen for high blood pressure or hypertension.
Okay, great. Thank you so much. A lot of really important information there. And as a reminder to our audience members, we are recording this, so you can certainly go back and listen to anything that might be helpful to you. All right, let's go ahead to Dr. Jackson. Keeping along the same lines, how often should women see their OBGYN, and does the frequency change for different age groups?
Thanks, Sarah. Like Sarah said, I'm one of the OBGYNs. I see patients here in Center City. You can tell from Dr. Boyle that primary care doctors have a huge job keeping track of all these screenings for different people. So as OBGYNs, we're a little bit more focused. We also like to see people once a year for an annual checkup. It used to be many years ago that the annual exam was really tied to Pap tests. This has changed as we've learned more and more about cervical cancer, and we've learned who's at risk for cervical cancer. So while most people don't need Pap tests every year, we still want to see them for an annual GYN exam. We can check in about any issues with their periods, about any need for contraception or testing for sexually transmitted infections. Later in life, we can talk about any menopause issues. We can talk about abnormal bleeding, really just to check in from a GYN standpoint and see how things are going. And typically we'll do a breast exam and a pelvic exam at that annual GYN exam. Really, those yearly exams can continue throughout time. For some people over 65 whose primary insurance is Medicare, they like you to come every 2 years. And as long as you're not having any problems, that turns out to be safe and okay.
Okay, great. Thank you so much. Quick follow-up to that. What about if a patient has had a hysterectomy?
It really doesn't change anything. We still like to see people after a hysterectomy. The one difference is if the hysterectomy was done for completely benign reasons and that person has no history of cervical dysplasia, she wouldn't need any more screening for cervical cancer as she doesn't have a cervix. But we would still see her once a year for an annual GYN exam.
Okay, thank you so much. Helpful information once again. All right, turning to Dr. George, question for you. Can you talk a little bit about healthy aging and wellness for women of different age groups? What are some of the best preventative measures women should take in their 30s, 40s, and even beyond?
Sure, Sarah, I'd be happy to chat about that. As a family medicine provider whose focus is really on keeping people healthy, I really love this question because it's, I think, some of the things that I chat with all of my patients about on a daily basis. So it's nice to have a forum to sort of share that message en masse. I think one of the most powerful things that we can do to stay healthy throughout our lifespan isn't doing a screening test and isn't taking medications, even though those things are very important when they're indicated. But really the fundamentals of prevention and healthy living is what we call a healthy lifestyle or lifestyle factors. Essentially, that means, the way that we move our bodies, how often we move our bodies, what we feed our bodies with, how much exposure we have to tobacco products and alcohol as well. So I want to kind of break those down a little bit more into some more granular detail, because I think sometimes when we say lifestyle factors, people are a little bit overwhelmed by what that actually means. In terms of physical activity, the CDC really recommends that we get at least 150 minutes of physical activity, moderate physical activity each week, and that 2 of those sessions should be some sort of strength-based training. And that sounds like a lot, kind of depending on where you might be starting from. But the great thing is that we know that you can accrue that in any way you wish, whether that's breaking up in 10-minute segments multiple times throughout the week, or doing 2 or 3 kind of longer sessions. And really that moderate physical activity can comprise of anything that you like. And that can be going to the gym or doing a home-based workout, or doing some chores around the house, or working in the garden. So I think we have a lot of flexibility there, even though 150 minutes per week might sound really tough, depending on how busy and what your life looks like. We also know that even if you can't hit that 150 minutes per week mark, that any activity is better than none. So really encourage people to get moving. And getting moving helps you maintain your weight. It helps you get better sleep. It helps, reduce your risk of heart disease and obesity, and also just helps you feel good. So there's multiple reasons why that's really one of the foundations of a healthy and prevention lifestyle. The other piece of that is really how we feed our bodies. And again, I think this can seem intimidating to people, especially because food culture is so important to just culture overall, and it's hard sometimes to change our food preferences and habits and what our family loves to eat. But essentially, rather than having people follow a specific diet, I really like to use the US Department of Agriculture's sort of My Plate plan, which is more of a framework than it is a specific diet, but essentially encourages people to see their plate as something that they divide into half, and half of that plate should be filled with fruits and vegetables. And then the other half, you can again cut that half into half. So you have 2 quarters, and one of those quarters should be whole grains, starchy vegetables, and the other quarter should be some sort of lean meat. So I think if we think of conceptualizing a meal like that, it can really help people, because then that means they don't have to necessarily give up food traditions that they really enjoy. Another thing that I think is really important to mention, and I am by no means endorsing a vegan lifestyle because I certainly can't do it, but we know that a plant-based diet, or at least a diet filled with plant foods, is really important for protecting our cardiovascular health, and again, reducing risk of certain cancers, reducing risk of a whole bunch of different things. But for some people, some people are awesome and they can be vegan, but most of us, I think, enjoy meats. So what that means for us is, again, thinking about filling most of our plate with fruits and vegetables, and thinking about maybe incorporating one day in the week, like Meatless Mondays, I know is a trend, or substituting one meal each day that has no animal products in it. So that's the second kind of big piece of lifestyle changes. And the last 2 pieces that I'll mention are really avoidance of tobacco in all its forms, whether chew it, hookah, smoking cigarettes. We know that tobacco exposure is still one of the biggest culprits in terms of preventable causes of death. And it affects every single organ system. So no organ system is really safe from tobacco. And if you can't cut down because it's difficult for you, then really working to reduce your risk by reducing your exposure. And the final piece, I think we don't talk about enough, because alcohol is a socially acceptable substance. but thinking about moderating our use of alcohol. And I think people are always surprised when I tell them what that means. But for women, that means 1 standard drink a day on average. And for men, that means no more than 2 standard drinks a day on average. And a standard drink is 5 ounces of wine or 12 ounces of beer or kind of standard shot of liquor. So it's a lot, I think, less than most of us are used to thinking is kind of normal. So that being said, that's sort of prevention in a nutshell. I think is some of the most powerful things that people can do. Although, you know, we might get questions from the audience about how to make that happen from a practical standpoint in our modern day lives. And I think that's certainly a separate question I'd be happy to chat about as well. I don't have the answers, but.
Okay, great. Yeah, you heard it. Feel free to pop your questions in the chat and we can answer those later on. But thank you so much for kind of breaking down those lifestyle factors and, you know, to your point of not following a strict diet, but keeping in mind that framework, I think that would be really helpful for people. So thank you for sharing. Okay, Dr. Jackson, let's turn to you. A more specific question for you here. Is there an age when women don't need to get pap smears anymore?
Sure. So I mentioned earlier, we've really learned a lot about who is at risk for cervical cancer and the best way to screen for cervical cancer. And it turns out that cervical cancer is very much related to infection with a virus called HPV. And we now have the ability to test for HPV. So typically for women over 30, along with any pap test that's done, we also will test for HPV. For people who have normal cells on their pap test and negative HPV tests, that can be repeated every 5 years. And if all normal and people are up to date on screening, it can stop at the age of 65 because the risk of cervical cancer developing at that point is so incredibly small. The other group of people I mentioned earlier are people who have had a hysterectomy for benign reasons like fibroids, who have no history of abnormal pap smears. As long as their cervix was removed with the hysterectomy, they no longer need cervical cancer screening.
Okay, great. Thank you so much. All right, Dr. Boyle, let's turn to you. Let's talk about menopause for a bit. Is it possible to have a smooth transition into menopause? And are there certain things someone can do to help with any struggles during menopause?
Sure. I think that's a fantastic question. And I think Dr. Jackson and I mentioned this before, but this is something that both your PCP and your OBGYN can address. So don't feel like you have to talk about menopause with your OBGYN. Many primary care doctors can discuss it with you. So I think the most important thing in terms of managing the stress of menopause or perimenopausal timeframe is knowing what to expect. So I'll just kind of go over what some of the symptoms are, and then we can talk about some tips and tricks for managing those symptoms. So the average age of menopause in the US for women is age 51. But the best predictor of when you will go through menopause is the age at which your mother went through menopause. So if you're not sure about that, now might be the time to ask your mom so you have an idea of when to start expecting some of those symptoms. It's not a perfect prediction model, but it's a good start. And so what are the most common symptoms of menopause? Well, up to 75% of women will have what we call vasomotor symptoms, which is hot flashes. Or if the hot flashes occur at nighttime, that's what we call night sweats. And then the other most common cause or menopause symptom is vaginal dryness or vaginal atrophy. And so those are some very common symptoms that people might present with. However, those are not the only symptoms that women will experience throughout menopause. Women might complain of sleep disturbances, mood changes, cognitive issues, and even sometimes musculoskeletal issues. Sometimes it's not entirely certain if those are attributable to their menopause, but sometimes they might be. So what do you do? I think I'm mostly going to focus on the vasomotor symptoms and kind of hit on that, since up to 75% of women can have that. And that seems to be the most bothersome symptom that women might experience. And so what can you do to kind of help ease the transition into having these hot flashes? Well, we always recommend lifestyle modifications. So the first thing that I would recommend for people to do is lifestyle modifications around hot flashes. So lowering room temperatures, dressing in layers just in case they have a hot flash at work. They can also try and avoid triggers like spicy foods or alcohol. Those are some things that might be helpful, and they might not be helpful. And if they're not helpful, then don't feel like you have to continue doing them. There is some evidence that cigarette smoking can worsen vasomotor symptoms. And so this might be the extra push somebody needs to think about quitting smoking at this time. And so if you are smoking and you think, you're about to go through menopause, your mom went through it around age 51, and you're coming up on it, there's tons of resources that your PCP can talk to you about to help with stopping smoking. Other things that have some limited data that are lifestyle changes you can make are things such as weight loss. Now, if somebody came to me complaining of hot flashes, I'm not going to tell them that you should lose weight, because obviously that takes time and the hot flashes are going to continue in that time. So if that's something that you can kind of think about preventatively, if you have weight that you can lose, to try and do that before you go through menopause, and that might ease some of the symptoms that you're having. One of the other lifestyle modifications you can do is mindfulness. And while that does not decrease the frequency or the severity of your hot flashes, it might help you manage the stress. So that's also not a bad option. And then in terms of once you kind of turn to providers to see if there's any help, there is some evidence that both cognitive behavioral therapy, which is a type of therapy you would have with a therapist or a psychiatrist, as well as hypnosis, can help a little bit with vasomotor symptoms. Additionally, there's some data that phytoestrogens, or which are estrogen-like compounds found in soy products mostly, can help ease some of the symptoms from menopause. However, there's not a perfect dose or a certain amount you should be eating. And so it's not necessarily a foolproof method, but if you'd like to try it, you can certainly try incorporating some soy products into your diet. And then there's some ineffective therapies, and these are things that I wouldn't recommend for people. And these really mostly are over-the-counter supplements and herbal remedies. So that's the things you might have heard about, like black cohosh, or evening primrose oil, or dong chi. And I don't know if you have heard of any of these things, but if you do a quick Google search on menopause, they will likely pop up. And they have been studied, and they're fairly ineffective. And so I wouldn't really recommend bothering with those, especially because some of them can have side effects that are not great for the rest of the body. And so I would take your risks and your benefits and probably just skip out on those. And then, if you've tried all of these at-home remedies and you're still having a hard time, you can come talk to your PCP or your OBGYN about medical therapies that we have and can offer to people. That includes both hormonal and non-hormonal options. So if you have an aversion or a medical reason that you can't have hormone therapies, there are other options like SSRIs, SNRIs, or gabapentinoids, which are some non-hormonal options to help manage hot flashes.
Okay. Thank you so much. A lot of important information there, and nice to hear about some of those lifestyle modifications that people can try, and also what not to try. So thank you. Okay, one more question for you. Could you talk a little bit about perimenopause?
Yeah, definitely. So perimenopause is the time leading up to menopause. And so menopause is defined, it's a clinical diagnosis. And what that means is it's defined by retrospectively by 12 months of having no periods in a row. So if you had 5 months of no menstrual cycles and then you have another period, then you have to start the clock over again. And that's really when people are in that perimenopause timeframe. So during this timeframe, your ovulation doesn't seem to happen just every month, but it might happen every 2 or 3 months. So your periods might start to space out a little bit. They might decrease in flow. And women might start to notice some of those menopause symptoms that we mentioned, like hot flashes, night sweats, and then sometimes vaginal dryness, although that symptom tends to get worse the further out from menopause that you are.
Okay.
Sorry, I think, apologize. Sorry.
No worries. And we can also turn to Dr. Jackson as well, if you'd like to add anything there.
I think Dr. Boyle gave us a great summary, and I think it really highlights what she said at the beginning, which this is something that I, as an OBGYN, am very happy to talk to patients about, and most primary care doctors are also happy to talk to their patients about. At the end, she was talking about some of the bleeding changes that people might experience. And I'd also say it's a time to look out for abnormal bleeding patterns. So it's very normal to skip periods. We expect that leading up to somebody's final menstrual period. What we don't want to see is for people to bleed in between their periods, or bleed more often than every 21 days, or have periods lasting for more than 10 days or 2 weeks at the absolute longest. Those are bleeding patterns that we'd want to evaluate. And Dr. Boyle did a great job of explaining symptoms that people can expect. One of the hard things for me, I think, in terms of giving people anticipatory guidance towards menopause is just that everybody's experience is different. And if you're my age and you have friends who are perimenopausal or menopausal, you'll talk to 5 of them and they'll tell you totally different stories about what their experience is. So it's a little bit of wait and see what it's going to be like for you. For some people, it is a really challenging time, and for others, it's really not bothersome at all.
Okay, thank you. An important message to keep in mind, so we appreciate that. Okay, let's continue on with our questions for the evening. Dr. George, we'll turn to you. Let's talk a little bit about weight loss drugs. I know we've been seeing a lot about weight loss drugs in the news lately, and just curious to hear your thoughts on these for weight loss. And maybe if you could just go over what the pros and cons are for these medicines.
Sure, I'd be happy to. I hope I can do this topic justice in the short time that we have. But maybe first, before I talk specifically about the weight loss medications, I'll take just a step back and try to put this question into context. We certainly are, as a society, both nationally and globally, we are definitely seeing an increase in weight-related health issues. At the same time, it's also true that there's a lot of unnecessary kind of weight-based stigma and bias against larger bodies that we need to be mindful of, especially in medicine, that we don't attribute just to weight. That can really contribute to negative self-images and unhealthy eating habits for people who become really dissatisfied with their bodies because of the stigma that exists. So before we talk about medications, I just want to message clearly that being skinny doesn't equate to being healthy, and that the goal of weight loss medications is to work in conjunction with other habits, healthy lifestyle habits, to help people become metabolically healthy as opposed to becoming skinnier. And I also want to say, I think for a lot of folks who trained like me in our medical training, there was I think an overly reductionist approach to weight loss, that weight loss is simple as calories in minus calories out. And now we know it's really not just that simple, and that really there are many other factors that contribute to the size that anyone is, including their genetics and their environment, and also the simple fact that our bodies really try very hard to maintain homeostasis, which makes it really hard to lose weight. And even if we do lose weight over time, we see people trend back to this set point that their body might have. And that can be really frustrating for folks who are doing their best. So hopefully that tangent makes sense, and it probably already tells you how I approach the FDA approved medications that are available. I'm really happy that there's another toolkit in my tool belt to be able to help people kind of get to a healthier place metabolically and in terms of their weight. and I use these where I can. To be very practical though, oftentimes what dictates which of these medications I can prescribe for my patients is their formulary. Depending on what type of insurance you have, it may be prohibitively expensive or almost impossible for me to get this approved for you, but there are some medications that are generic, so I can sort of hodgepodge put things together using generic medications. But overall, these medications are approved by the FDA for folks who are have a BMI, so a body mass index that's more than 30, or have a BMI that's a little bit lower, but have a weight-related illness like sleep apnea. There's actually 5 FDA-approved medications. 3 of them have been on the market for a long time. I know there's been a lot of interest in the last year, less than maybe 6 months or so, with the injectables, and injectables are sort of the newest and the sexiest drugs on the market, but there have been some drugs on the market for some time now. The 3 older ones are oral medications. The 2 newer ones are injectables, and the injectables differ in that one is a daily injectable, the other one is a weekly injectable. And I won't say the names, so I don't want to endorse any particular product, but some of you may be very familiar with a particular tycoon named Elon Musk, who has attributed his own weight loss to using one of the weekly injectables. But deciding which one to start, other than being really kind of dictated by your insurance formulary, depends on you and your your particular comorbidities. And there are some medications that are really contraindicated for women who are pregnant or are reproductive age who can become pregnant. So there is some decision making around that. That kind of depends on what you might be at risk for and what's safe for you. Speaking specifically to the injectable medications, because there's certainly been a lot of excitement around them. They've shown to be really effective. In one of the seminal studies for the weekly injectable, patients have been found to lose up to 14% of their body weight. And to put that in context, when I have a patient who has prediabetes or at risk for diabetes or is struggling with their blood pressure, the traditional knowledge is that if patients can lose 5 to 7% of their body weight, then that really mitigates their risk moving forward. So a 14 to 15% reduction in body weight is really very powerful. What I don't know, and maybe Dr. Boyle or maybe you might be able to help me with, is I don't know if we know just yet what happens when we withdraw those medications. The newer medications, I'll tell you that I know for the older medications, the oral medications that have been on the market for some time, there's pretty interesting data that, again, when we take those medications away, people can slowly creep back to their baseline. And I think that just means for us that we need to think about obesity as a chronic disease and treat it like we would. That's relapsing and remitting. But I don't know if that data exists just yet for what happens after we take away those injections when someone has lost weight over, 2 years or so.
Yeah, I mean, I think that my knowledge is pretty much the same as yours, Dr. George, in that these are fairly new medicines and there's not any great data on what to do in terms of stopping them. So, and I have patients ask me this regularly, is this a medication I'm going to have to be on for the rest of my life? And I have to be fairly frank with them that we just don't know yet. Some people are fine being on these medicines long-term, and if that works for you, then that's fantastic. But other patients want something that they don't have to inject for the rest of their life. And so we're kind of still waiting on the data as far as I know.
Yeah, so we'll see. And then I'm sorry, I forgot to answer the second part of the question, which was some pros and cons. Again, it depends on the medication. The injectable medications, there are some patients who can't use it at all. And that's a pretty small percentage of patients. And that refers to people who have a specific risk for a type of thyroid cancer. Otherwise, what really limits us is some people develop nausea, upset stomach, diarrhea. That's pretty disabling in response to some of these medications, and we never know who's going to react in that way.
Okay, well, thank you so much. Kind of interesting to hear these latest therapies, so appreciate you going through that. All right, let's take a few more questions. And I know we've been receiving a ton of terrific questions from the audience, so thank you all. We'll go through just 1 to 2 more submitted questions, and then we'll hop to the live questions for the remainder of this evening. But I will turn now to Dr. Jackson to talk a little bit about pelvic exams. So for women with a family history of breast cancer, when should they start testing and screening?
It sounds like a simple question, Sarah, but it's a little bit more complicated. And even for, I'm going to start, just back up a second, start with average risk women. So women at an average risk for breast cancer. And Dr. Boyle talked a little bit about this when she was talking about screenings in general. But if you look at different national organizations who make recommendations about screening, they're all over the place about when people should start mammograms. The National Comprehensive Cancer Network recommends that everybody start at age 40. And that's what you'll hear some physicians say. They'll suggest all of their patients start at age 40. If you look at the U.S. Preventive Services Task Force, they recommend that people start at age 50. And I have seen some patients who were told by their physicians to start at age 50. American Cancer Society is a little bit more wishy-washy. They say to offer it at age 40 to 45 and then to recommend at age 45. And then ACOG, which stands for the American College of Obstetricians and Gynecologists, which is kind of the governing body that dictates standards of care for OBGYNs, is maybe the most wishy-washy of everybody. And what they recommend for us is that we offer mammograms to people starting at the age of 40, and that we recommend it no later than the age of 50. And between 40 and 49, it should be shared decision-making. So after counseling of risks and benefits, and the big risk of mammograms for young women is the risk of false positive tests, which is very anxiety provoking. So that means somebody has a mammogram, they see something, they get called back for maybe another mammogram, maybe an ultrasound, maybe a biopsy, when actually their risk of breast cancer is quite small. So after that conversation between the age of 40 and 49, somebody might decide that she's anxious enough about breast cancer that she wants to start screening. And other people will decide that they don't want that risk of false positives. They understand their risk of breast cancer in their 40s is low, and they're more inclined to start at the age of 50. So that's if you take average risk women. Now, if you start to look at women who are at higher risk for breast cancer because of a family history, it's really going to depend on a lot of specifics, and most notably at what age people were diagnosed. And most people will recommend starting screening 10 years younger than the youngest person was when they were diagnosed with breast cancer. What that screening looks like will depend on a person's specific risk. So for people who have a family history of breast cancer, they should have a formal breast cancer risk assessment. There's a few different tools, but a few of them will tell you your lifetime risk of breast cancer. And for people who have a lifetime risk of breast cancer that's higher than 20%, that's considered high risk. And for them, the screening should be not just a mammogram, but also they qualify to have a screening breast MRI, which is typically done once a year, alternating by 6 months with a yearly mammogram. So it really, I think, becomes a very specific conversation between a patient and her physician, again, primary care physician, OBGYN physician. And here at Jefferson, we're lucky enough to have a high-risk breast center where people with a significant family history can talk to a specialist about both screening and some prevention options as well.
Okay, thank you. Definitely not as cut and dry as just answering a simple question. So thanks for detailing that. All right, let's go to our last question and then we'll hop to the live questions. So Dr. Boyle, an interesting question just about new trends in the field. Are there any new trends or upticks in women's health issues since the pandemic began?
Yeah, so there have definitely been trends, and then definitely some health issues, and that's probably more what I've noticed is certain health issues that have popped up. And I will just go ahead and caveat this, that these are largely my experience practicing in terms of what I've noticed. And I think that there are some data to back up some of these. So one thing, and that Dr. George mentioned earlier, is alcohol consumption. That tended to increase quite a lot during the pandemic. I think that people were at home, weren't able to leave the house, and a lot of people did increase their alcohol consumption. And so what I was going to stress, but I think Dr. George did such a great job describing, is that for women, we recommend staying under 7 drinks in a week. And so if so a lot of times people don't realize that that was the recommendation. And so kind of reiterating that to my patients has been really important during this time. And then something else that has popped up a lot is anxiety disorders. I think both anxiety from, like we said, being stuck at home, new life stressors, and then also a lot of illness-related anxiety has been popping up, and which makes a lot of sense given the COVID pandemic. So obviously I encourage people to come see their PCP if they have anxiety. Therapy is a really great option for everyone, but some people do require medicine, and that's something that we can help people with.
Thank you. And Dr. George, anything you'd like to add there?
Yeah, I'd like to also add, there's been a really disturbing uptick in intimate partner violence, both nationally and globally. You may be familiar with the older term domestic violence, but intimate partner violence is sort of more all-encompassing and doesn't just include people who are married, but could be partnered and living together. And intimate partner violence affects everyone, all genders, but women are obviously disproportionately affected. And I think some of that had to do with, like Dr. Boyle said, the uptick in alcohol use, but also, people losing income and financial stability and loss of childcare, and also the closure of some of the social resources that people rely upon. So we've also seen that as well.
Okay, thank you very much for going through that. Okay, let's turn to live questions. I know we've received a bunch, so thanks so much everyone for submitting those. And we have a fun question to start with. I really like this question for whoever submitted it. So feel free to just chime in. This will be for all the docs, this first question. Do you have any recommendations for health-related holiday gifts? So if any of you has an idea, feel free to chime in and let us know. Putting you on the spot here a little bit.
I think it depends on your budget. There's certainly been a Peloton kind of surge of interest. And I'm not talking about the bike, because the bike is, I think, prohibitively expensive, and that would be really nice of you to buy someone that gift. But there's an online subscription that also includes things like classes and sort of motivational stuff like yoga and meditation. I think that's a really great way to get people started in caring for themselves and getting them active. And then I think Fitbits or other sort of wearable health technology, again, is another really awesome way to get people competitive and motivated to get moving throughout the day.
Great. Dr. Boyle?
Yeah, I can chime in. So this, I actually had not thought of this until this exact moment, but I think something that could be fun, the winter months, especially in Philadelphia, tend to be cold and snowy. And so people tend to stay indoors a lot more often. So maybe a fun idea, health-related idea, could be something related to an outdoor activity like snowshoes or ski tickets. Again, skis themselves might be a little bit cost prohibitive, but like a lift ticket to go skiing, and that's a good way to stay active during the cold.
Love that idea. Thank you. All right, we will go to the next question, but now I have some ideas for holiday gifts, so thank you. Dr. Jackson, a more specific question for you. What could cause excessive fluid inside the uterus of a menopausal woman?
That's a very specific question. So definitely something that you would want to talk directly to your gynecologist about. Sometimes it's nothing at all to worry about. Sometimes after menopause, the cervix becomes stenotic, meaning like closed very tightly, and the normal fluid just can't drain out of it. So you would also want to know how thick the lining of the uterus was on that ultrasound. And then the other thing is it could be blood in the uterus that would look like fluid, which would be a little bit more concerning and might require a biopsy of the lining of the uterus or some evaluation to figure out what's going on.
Okay, thank you. All right, we have one more follow-up question for you, Dr. Jackson. So yeah, be on standby here. Okay, I had a hysterectomy in 2018. This is from an audience member, but have not been checked since. And I am now having pain and discharge. What could be causing this and what should I do?
See a gynecologist. Pain, so when people have had a hysterectomy, there's different things that can be removed during the hysterectomy. So sometimes people still have their ovaries. Sometimes people can have an ovarian cyst after a hysterectomy. And then, as far as discharge, you can have the same vaginal infections after a hysterectomy that you could have even if you have a uterus. So people with a hysterectomy can have yeast infections or bacterial vaginosis, or even infections like trichomonas, and possibly less likely gonorrhea, chlamydia, things like that. So definitely needs to be evaluated.
Okay, thank you. So go see your gynecologist. Sounds good. Okay, Dr. George, question for you, and this is stemming from that lifestyle conversation, more specifically regarding diet. So what about a diet based on fish and vegetables, and what meats, birds, or fish are more or less healthy?
That's a good question. So yes, I would say having a diet filled with fish can be potentially very healthy, depending on how you prepare that fish. Some people do batter and fry their fish, which again is not the healthiest way to consume fish. And then there are some concerns about sort of, especially in women who are considering pregnancy, consuming undercooked fish or fish in excessive quantities, which might expose them to mercury. But that being said, we do know that like fatty fish, like tuna, which you can get even from canned tuna, and salmon, are really helpful in terms of the type of effect that it has on your cholesterol levels. So I do encourage my patients to increase their fish intake, because for most of the patients that I see, their balance of non-fish meats and fish is a little bit skewed. In terms of the sorts of meats that I really encourage patients to try to do less of are things like deli meats and processed meats. For multiple reasons, there is a small but significant increase in the risk of colon cancer that's been associated with deli meats and processed meats. Also, deli meats tend to increase their shelf life, tend to have a lot of sodium in them to preserve them. So that's works against people with elevated blood pressures or risk for hypertension. So that's really something that I try to have my patients reduced. And also red meats as well. So your porks and your beefs, and also their associated meat sources can also result in what we call dyslipidemia or abnormal cholesterol levels. So those are some that I really have my patients reduce. Now, again, depending on what your food culture is, there might be some dishes that are really important for you to eat, especially at different times of year. So I do not recommend elimination if that's not feasible for you, but just thinking about reducing that.
Okay, thank you.
And just to reassure, oh, I'm sorry.
Nope, go ahead.
Just to reassure people who are pregnant or thinking about becoming pregnant, everything Dr. George said is exactly right. But I do want to encourage you, it is safe and healthy to eat fish while you're pregnant. Just keeping in mind the mercury content. So big meaty fishes like swordfish have a lot of mercury in them and should be avoided during pregnancy. But white flaky fishes like tilapia, salmon, shellfish, shrimp, all have very little mercury in them, and you can have them up to 3 times a week when you're pregnant.
Okay, great information there. Thank you so much for chiming in. Okay, one more question for you, Dr. George, kind of related to diet here, question about water consumption. How much water is appropriate to drink each day? I feel like that's the age-old question. And does that change with age?
That's a great question. None of us drinks enough water, I can assure you. There's actually a calculation that I do not remember off the top of my head right now for how much water we should try to consume each day. I generally tell my patients to aim for anywhere between half to 1 gallon of water a day. What we also know though is I think, so I was trained that other liquids don't count as water, including things like tea and caffeine, but there's been some rethinking around that. That actually caffeine doesn't only dehydrate you, it actually adds to your fluid intake as well. So that can include things like tea and caffeine. I would not include things like sodas in that fluid consumption because we know that it, the excess sugars really lead to increased weight gain in patients. As you get older, they're depending on sort of medical issues that you may be dealing with, especially if you have things like heart failure. You may want to discuss with your doctor specifically what the limitations are for you in terms of your fluid intake, because there are some other considerations that come into play. And then some people, as they get older as well, may struggle with incontinence-related issues, especially incontinence at night. And so they may want to shift their fluid intake to the morning, or they may want to reduce their fluid intake after a certain time at night so that they're not up at night urinating all night. But I would still say shoot for about half a gallon at least of water a day. Okay.
I have to drink my water after this. I'm feeling thirsty all of a sudden. Thank you so much. Okay, Dr. Boyle, question for you. What's the difference between seeing an internal medicine doctor compared to a primary care doctor? Very good question, and I feel like a lot of us probably have that.
Yeah, that's a fantastic question. And I think that people are continually confused about what the difference is between family doctors and internal medicine doctors. And the reality is not too much, but I'll go over some of the differences. So family medicine doctors, and Dr. George, you can kind of comment in as you see fit, train on the whole spectrum of ages. So they are trained to learn about pregnancy and obstetrics, and then they are trained to take care of children as well as adults and aging populations. Internal medicine doctors are trained specifically to take care of adults and aging populations, so age 18 and up. So I don't take care of children, and I will take care of pregnant women for their medical issues, but not for their obstetric, I don't want to say issues, for their obstetric visits. And so that's the main difference. Internal medicine doctors can be primary care doctors like myself, but they are not always primary care doctors. They can do hospital-based medicine work, or they can move on to a subspecialty like cardiology or gastroenterology. And so sometimes they develop skill sets in other disciplines.
Okay, perfect. Anything you'd like to add, Dr. George? I think that covered it. Great. Thank you so much, Dr. Boyle. All right, Dr. Jackson, question for you. Another specific question here. I've been diagnosed with fibroids. What steps should I take regarding family planning?
I don't want my answer to everything to be you should see your gynecologist. but it really depends on the size and the location of the fibroids. If women have fibroids so fibroids can be different places in the uterus. And if fibroids are inside the uterus, which people call intracavitary fibroids or submucosal fibroids, if they're interfering with the place in the uterus where a pregnancy would grow, those often should be removed before somebody tries to get pregnant. But if fibroids are in the muscle of the uterus or on the outside surface of the uterus, very often we recommend not doing anything about the fibroids prior to pregnancy. But it really would depend on the specific size and location.
Okay, thank you. All right, next question, and this can be for anyone who wants to hop in here. From the audience member, I've been diagnosed with bladder prolapse and want to avoid surgery. Is that possible? And what exercises should I do to strengthen the pelvic floor? I do Kegel exercises. Is there something else I should do? And is there a specialist I should see? So if anyone wants to hop in here, that would be great.
So this is a great place for pelvic floor physical therapy. So most people know if their shoulder is weak, they'd see a physical therapist and strengthen their shoulder. Your pelvic floor is the same. So for prolapse and for incontinence, and even for some forms of chronic pelvic pain, pelvic floor physical therapy is highly effective. Just a plug for the pelvic floor physical therapists here at Jefferson. They are amazing. And they will design an exercise program unique for you. So they'll spend quite a bit of time talking to you, and then to do an exam and figure out exactly where your weakness is, and then give you an exercise program that's tailored for you to strengthen those muscles.
Okay, thank you so much.
I think the other thing I'll add, and Dr. Jackson will know this better than I do, but there's also the option of pessary use as well, as a non-surgical option for folks for whom pelvic floor therapy doesn't work. But a pessary is almost like a plug device. Plug just sounds very archaic, but essentially it helps to support the pelvic organs, and it's inserted during an office visit, usually by a GYN doctor, although there are certainly some primary care doctors who know how to do this. I am not one, but essentially they will place a plug inside of your vagina to support some of your organs and can help with some of those symptoms too.
That's a great point. And I'm sorry I didn't mention that. I was so excited about physical therapy, but yes, the pessaries come in different shapes and sizes. It's something that's placed, just like Dr. George said, placed inside the vagina to physically hold up what's prolapsing.
Great. Well, good to hear that there's different options as well. So thank you both. Okay, this question, next one for Dr. George or Dr. Boyle, so feel free to hop in here. From the audience, I'm experiencing thinning hair. What could be causing this? And are there labs I should have taken to test for any underlying causes?
This is a good question. I have a lot of patients who I see for thinning hair. There are so many things that can contribute to thinning hair. So I think really speaking to your doctor about the specifics of your condition are really helpful. But to give you a sense of things that can lead to thinning hair, some things are mechanical, like there is a condition called traction alopecia. And just like the word traction suggests, it's really related to mechanical forces of pulling the hair in a particular hairstyle over time. So typically we see people, for instance, who might pull their hair back into a low bun, and they may have some thinning at the front of the scalp because the hairs at the front are being pulled all the way back. And if that happens over time, you can even lead to chronic hair loss there that doesn't regrow. So that's an example of something that's very specific to pulling the hair back. There are also different scalp-related disorders that might cause thinning hair. So for instance, extreme cases of dandruff, which we call seborrheic dermatitis, can lead to people to really scratch their hair because it's so itchy and can lead to hair falling out in some places. And then there are also systemic or diseases that affect the entire body that can also result in thinning hair. things like vitamin deficiencies and severe anemia and thyroid issues. Other things like PCOS can sometimes have result in people having thin hair. Some medications may also result in people having hair loss. And then other things that I think women are surprised to find out, like in the postpartum period, for instance, women might find that their hair fall out at alarming rates. And thankfully, after about a year or two, that grows back, but it can certainly be very distressing. And then in some families, there is what's called female pattern hair loss, where essentially you're at risk as a woman for having kind of thinning hair because it sort of runs genetically in your family. So there are lots of different things. There are probably some tests that your provider can do a sort of just do a basic evaluation, but they will want to see you take a look at your hair and get a sense of whether this is something that's specific to the scalp or the hair, or whether there's something larger, something bigger going on.
Okay, so a good idea to see your provider. Thank you. All right, so I know that we're just over an hour here, so we'll have one last question and then close out for the evening. But this could be for anyone, whoever wants to answer. What are your thoughts on hormone replacement therapy, and would you recommend it?
That's a big last question, but I'll start. So it really depends on people's symptoms and how much they're interfering with their day-to-day life. People who are symptomatic with menopause, who are less than 10 years from their final menstrual period, who are less than 60 years old, and don't have any medical problems that make hormone therapy not safe for them. I think that for most people, hormone therapy use for a short period of time to get them through that menopause transition is a great idea. That would be sort of my short answer. We could spend a whole hour talking about hormone therapy, but that would be my short answer to the question.
Okay, thank you. And any additional thoughts, Dr. George or Dr. Boyle?
I agree, and I think just to be explicit about the risks is there's been data that has shown that women, especially as they are further away from menopause, who are exposed to hormone therapy, are at higher risk of cardiovascular disease. So that's sort of where that recommendation comes from, to limit the amount of time that women are exposed to hormone therapy, and to also think about how long it's been since they transitioned to menopause that we initiate that therapy for them.
Okay, well, thank you. All right, well, we will end. I said one final question, but I have just one more for you. What are your goals for everyone listening tonight? I think this is always a helpful question for our audience members. So, what do you want our viewers to take away from tonight? Any lasting thoughts from you? Feel free to share. Dr. George, we'll go ahead and start with you.
Sure. I think this gets lost in the day-to-day of our very busy clinic schedules, and I always feel like I'm remiss in sitting down with patients and talking about how powerful lifestyle changes are. But more powerful, yes, medications are extremely important, but they should be thought about as part and parcel of a toolkit that has to include also caring for yourself physically with healthy food, exercise, and limiting alcohol and tobacco. And those are some of the things that you can do on your own while you work with your doctor to provide the ancillary things that will secure your health.
Okay, thank you. Dr. Boyle?
Yeah, so I think that my goal for everyone would be to try and have some agency in your health. It's really important to kind of have that motivation to be really healthy. And, having a great doctor can only go so far. So I really encourage everyone to try and understand things about their health. And if they're confused about things, I really encourage you to ask clarifying questions with your physicians, because as oftentimes we might not realize that we say a big medical term and didn't stop to explain it. So I think that it's really important to just, continue asking questions and understand your health situation, so that you can take the steps that are necessary to lead the healthiest version of your lives.
Wonderful. Thank you. Advocating for yourself. I think that's a great message. All right. And Dr. Jackson, last but not least.
I agree with everything that Dr. George and Dr. Boyle said. I think it's important that, you do come to see us for your annual exam. Come with questions. There were so many questions in the chat tonight. Obviously, people have questions about their health. Come armed with your questions, and we'd be glad to answer them in more detail.
Yes, and to reiterate, thank you again for all the submitted questions this evening. We definitely had a wonderful, engaging discussion. So I know I appreciate it, and I know I learned a lot. So thank you. Well, thank you again, Dr. George, Dr. Jackson, Dr. Boyle, for your time this evening. As I mentioned, a lot of great information was shared. And thank you again, audience members, for your wonderful questions, and for attending and listening in and advocating for your health. We will be posting an event survey, so you can let us know your thoughts. Was this helpful? Is there another time that works better? Any other specialties you would like to hear from? Your feedback will bring more virtual events like this to you, the patients. And if you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please fill out the last question in the event survey. And be sure to visit jeffersonhealth.org to make an appointment, as well as stay up to date on upcoming events and webinars just like this one. We have more webinars coming up in December, so we'll share those dates and topics in just a moment. Please also visit the healthnexus.org for health content, patient stories, research, innovation, and much more. You can also visit the Jefferson Health YouTube page to view other wellness webinar series events. We have various topics ranging from back pain to planning for pregnancy to robotic surgery. A recording of this event will also be sent to you next week, so you can rewatch at your convenience. If there is anything anyone here at Jefferson can do for you, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Thank you and have a wonderful evening.